We are at CRT 2014, and the topic is a single stent with provisional stenting of a second side branch or a dedicated side branch covering the bare metal stent. We are talking about the TRYTON trial, and this has been a rich source of information on a variety of stent-related bifurcation issues. And I am with Dr. Philippe Généreux, who is the director of the angiographic core lab at the Cardiovascular Research Foundation and an interventional cardiologist up in Montreal. All right, remind us again about the TRYTON trial first off before we go into this specific presentation here, which is an award winner, by the way, at Impact Trial at CRT.
Yeah, sure. So we may remember the TRYTON trial was presented by Dr. Marty Leon at TCT last year, and you interviewed him on this topic, actually. Quickly, we know that bifurcation are frequent, 15% of a lesion subset in patient, and there's still a debate, actually, with what is the best treatment for bifurcation? Is it a single stent in the main branch and a POBA or a provisional stenting of the side branch, which actually all the trials show that it may be the more beneficial strategy based on prior trial? Or does a dedicated bifurcation stent, such as the TRYTON stent, could improve the prognostic of patient? So the main finding of the TRYTON trial mainly were it failed to achieve the non-inferiority in this primary endpoint. So the primary endpoint actually is a composite endpoint of target vessel failure, including target vessel MI, cardiac death, and revascularization, clinically driven. And it failed primarily the primary endpoint by an increase in target vessel MI, mainly. The TRYTON trial was mainly was supposed to be conducted in large side branch, meaning more than 2.5 millimeter visually estimate. That being said, it may met its secondary power endpoint, a superiority powered of diameter stenosis at follow-up, decreasing actually the diameter stenosis at 9-month angiographic follow-up. So what we intend to do actually is to look, what if the TRYTON trial would have been conducted only in real large side branch, meaning 2.5 millimeter by visual estimate. And we found actually in the current TRYTON trial, only 41% of the patient met the inclusion criteria of side branch more than 2.5. Many situations can explain that, maybe mainly the enthusiasm of the investigator to enroll in this great trial. Mainly the vessel size was 2.0 or 2.25 in this trial. So clearly not a trial in large side branch. So when we look specifically in the intended cohort, so side branch more than 2.25 by core lab, meaning roughly more than 2.5 by visual estimate, we saw a totally complete different trial. What we saw actually, we saw that the TRYTON stent met its primary endpoint of target vessel failure with a striking reduction in target vessel failure, once again mainly driven by target vessel MI. Also, it's reduced the target vessel MI compared to when we play in small branches. So the main finding of this sub-study of TRYTON trial is there is a strong interaction between the treatment strategy, meaning two-stent approach or single stent approach, and the size of the side branch. I mean, the conclusion of that is if you have a small side branch, it's a good news. You don't need to agonize to treat it. You don't need to agonize to put a second stent. It will rarely be expressed clinically. However, if you have a large side branch, such as more than 2.5 visually or 2.25 a core lab, you may have a benefit to keep it open. And the TRYTON stent give you this luxury of having less stenosis at follow-up. So that's the main finding of the large side branch sub-study of the TRYTON.
I mean, the figure was just striking. The bifurcation, if you will, between the two sizes, the 2.25 less versus more. Were you expecting anything like that?
Yeah, it's funny actually, because when you design a trial, of course you have an hypothesis, and the hypothesis was good to say that if we keep open a large side branch with a large area at risk, a large muscle area of the myocardium at risk, you may have a benefit. So I'm not surprised at this extent to see that when you keep open a side branch, you in a large vessel with a large myocardium, well, you have a benefit. Otherwise, we all have the gut feeling that if you start to play with small, insignificant side branch, yes, you may pay the price of more MI after the procedure with no real gain, because these small vessels rarely express themselves clinically with symptoms or revascularization. And it was striking actually to see the discrepancy in the TRYTON trial between binary stenosis. Roughly 25% of the patient had a DS, a diameter stenosis of more than 50% at follow-up, and only roughly 4% need clinically driven revascularization. So there is a discrepancy between what we call late loss and symptoms, because you need to reach a certain threshold to have symptom in this angiographic surrogate marker. So at this extent, I'm not surprised to see that if we keep open a large side branch, we do better. And I'm not surprised either to see if you play with small insignificant side branch, you may harm with more MI. That being said, the MI were not spontaneous MI. They were small periprocedure leak of troponin and CKMB, which did not express themselves clinically by either death or revascularization.
Now, this is one of 6 impact trials, Généreux et al., and it's the TRYTON bifurcation trial in the de novo true bifurcation lesions. And for more information from CRT, please make sure you go to CardioSource World News. From CRT 2014 with Dr. Généreux, I'm Rick McGuire, Executive Editor.